No, thanks very much, Dr. Fearon, and pleasure to be here. Thanks very much for the invite to Conor and to Maria and everyone from Dystonia Ireland. I'm delighted to be able to hopefully give a little bit of an update about the deep brain stimulation program we have in Ireland. I've included Dystonia Ireland on my slide there because, like many training neurologists and young researchers in Ireland, I owed certainly a large portion of my funding to Dystonia Ireland back in 2005, 2006 when I was doing some research with Michael Hutchinson in Vincent's Hospital. And certainly without that I wouldn't have been able to travel to Toronto, as Conor says, to train further in movement disorders. And certainly without going to Toronto I wouldn't have got a job back here in Ireland and wouldn't be here to work in the DBS service. So it's just important to recognise, I think, the value of Dystonia Ireland and the contribution as an organisation it has made towards developing neurology in Ireland, and it's important to acknowledge that today. So I'll try and get the clicker working. So I'll try and not make it too heavy. Some, like all talks, some will be less relevant to some people and more relevant to others. And of course we'll take questions at the end. So deep brain stimulation is a surgical therapy where we are using electricity to try and modify the way the brain works. And of course modify the way a brain works where certain aspects of its performance are causing difficulty with movement in particular. It differs from conventional neurosurgery in that it doesn't involve removing brain tissue or destroying brain tissue, which would have been what we have done in the old lesion therapies. And it aims to restore a more normal pattern of brain activity, which I'll touch on in a little moment. Important to say, of course, it carries significantly more risk than other non-invasive therapies. So drug therapy and botulinum toxin therapy, Dr. Fearon will be talking about, always remain the first port of call. As always, it's important to get a right balance between risk and benefit. So hopefully this isn't too complicated, but just thought it'd be useful to review some of the anatomy I'll be talking about. So this is just a slice across a person's brain, if you like, just over the ears. And the basal ganglia, these structures in the middle part of the brain, are really of particular interest to neurologists and movement disorders neurologists, because these are the oldest part of the brain from an evolutionary point of view, and are critical, it seems, for regulating normal patterns of movement, particularly movements that we all take for granted, putting one foot in front of the other when you're walking, reaching into your pocket when you hear your phone ringing. All these movements that we take for granted, if the door bangs, your head swivels to the right, again, without really thinking about it. And dystonia appears to be a result of dysfunction within these circuits. So all these structures, along with the cortex, the motor cortex, kind of hum together and sing together with oscillatory activity and communicate through patterns of oscillations. They don't operate individually. And we know that, for example, patients who have strokes in this region can develop dystonia. Now, brain scans in patients who have primary dystonia are typically normal, but we suspect, of course, that there's something within the way these structures are talking to each other that's abnormal. So the original approach to performing surgery for patients with movement disorders was lesion therapy. As I alluded to at the beginning, that was essentially destroying a small area of the brain using temperature to reduce overactivity within a certain locus of those circuits. And of course, things have evolved since then, and deep brain stimulation has essentially taken over from lesion therapy, although lesion therapy still is performed in certain select cases. So the globus pallidus and the thalamus were the targets where neurosurgeons would have used effectively temperature or radiofrequency ablation to tap into that circuitry and to try and modify abnormal movements. So again, we know these structures all talk to each other. And sometimes I use the analogy when I'm talking to patients about a central heating system. And we know that the cortex appears to be overactive because it's getting signals in an abnormal way from these basal ganglia structures. So it's a bit like having a room in the top of your house which is excessively hot. And we know that the way that we presume that the way the water is cycling through the central heating system is abnormal. And what we're trying to do, I suppose, is try to find out where in the house the abnormality is. And there's something that's not quite clear. We have certainly some suspicions that the globus pallidus might be relevant. But but we know that tapping into any room in the house can modify what's going on in the attic where things are excessively hot. So what surgeons would have done with lesion therapy is destroy the top room. That would have certainly sorted out the heating problem, but of course there's collateral damage from the rooms next door. And what deep brain stimulation hopes to do, and I'll talk about that, is, I suppose, to tap into the boiler and modify the way the boiler is working without being destructive. The main concerns about lesion therapy, of course, was if the surgeon wasn't perfectly accurate, structures beside the area of interest would be affected. So speech problems, visual problems, and cognitive or thinking problems were a challenge. And it could only be done on one side of the body as well. So for particularly with generalized dystonia, where symptoms are on both sides of the body, it wasn't particularly helpful for both sides. And equally with cervical dystonia, where muscles on both sides of the body are involved. So that was one of the difficulties with lesional therapy. So then, of course, deep brain stimulation came about in the 80s, 90s, and of course up to now with increasing frequency, and hundreds of thousands of patients have been treated with DBS for various movement disorders worldwide at this stage. And DBS, of course, instead of creating a lesion within the brain, puts an electrode and leaves it in there. So previously, again, the surgeon would have placed the electrode into the area of interest, for example, the globus pallidus, and turned up the temperature effectively to create a little hole. What DBS does, and what was particularly in Grenoble in France, where a lot of the initial development in DBS happened, they realized that if they put the electrode in but attached to a low voltage battery, it can mimic the effect of a little hole, but without causing destruction of brain tissue. So it was actually over 40 years ago when the first DBS surgery would have been performed for patients with generalized dystonia. And again, as I said, it was attractive because you can operate on both sides. So effectively, once a patient gets through DBS surgery, you can essentially say that they are the same as they were before the surgery, once there have been no complications. There's, of course, a tiny electrode or lead left in place, which is about 1.2, 1.3 millimeters wide. All the surrounding brain tissue is left normal. And since the 80s, 90s, and certainly in the early 2000s, more evidence was accruing to provide trial multi-center-based evidence for the use of dystonia, for use of DBS in dystonia. So that's back to our anatomy where I started. And of course, the challenge, which was also a challenge in the original lesional surgery, is that the neurosurgeon has to get into the middle of the brain with a lead, and therein lying the risk. So the risk of a general anesthetic, where surgery is performed asleep, and the risk of passing through blood vessels as the leads are passed down through into the mid part of the brain. And of course, neurosurgeons we work with have massive expertise in planning the route to avoid blood vessels and minimize the risk of causing a bleed or a hemorrhagic stroke, which of course is one of the main concerns. So predominantly the globus pallidus will be the target, but also sometimes the thalamus. And sometimes some patients will have dual targeting with leads in both of these structures. This is not an Irish patient, this is a picture from abroad and just an example of what happens in some centres. So previously, and still to this day, some patients have deep brain stimulation awake. And this was useful because when the electrode was in the middle of the brain, the neurosurgeon and the neurologist involved could learn about this abnormal circuitry. And then that abnormal signal that would come back in the lead would also guide the surgeon into the place of interest within the brain. For dystonia, patients would be often anesthetized because of the discomfort, particularly, for example, positioning during surgery would be very difficult in an awake patient. But for Parkinson's disease, for example, or some other tremor disorders, patients are left awake. But for dystonia, generally the practice is for a sleep surgery. And generally worldwide is a move towards sleep surgery for deep brain stimulation. It's a long surgery. Patients can be under general anesthetic for 4 to 6 hours, which can be a significant challenge, of course, the older we get. Because certainly over the age of 70, no one's brain takes kindly to being put asleep and interfered with by a neurosurgeon. This was the old state of affairs in Ireland, certainly when I was training over the last 20 years. So various neurologists from various hospitals around the country would refer patients to the NHS. I mean, some fantastic and still have some fantastic colleagues in the NHS in centres like Bristol, Oxford, Liverpool, London, where deep brain stimulation has been performed. There's 18 centres now in the UK performing deep brain stimulation, including Belfast, which has been offline for the last couple of years. But that was the pattern. So patients, we really devolved all DBS activity to colleagues in the NHS. Again, patients did very well in the main, as you would expect, although of course the travel was arduous and difficult in a group of patients who often had significant mobility difficulties. And of course it made it hard for neurologists like myself to develop expertise within the country. And so it's certainly for a patient comfort and ease of therapy point of view, but also for the development of skills in Ireland, there was a huge impetus to bring deep brain stimulation to Ireland and to, I suppose, reclaim all this activity from the NHS, which we have relied on for so long. So a deep brain stimulation service was set up in the Mater Hospital. Prof. Tim Lynch, a colleague of myself, and Dr. Fearon in the Mater did a huge amount of work to push through, along with patient support organisations like the PAI and Dystonia Ireland, to push through for funding to staff a team of doctors and a neurosurgeon with interest in deep brain stimulations. Catherine Moran, who sends her apologies, as you've heard, today couldn't be here, but she's a functional neurosurgeon who works between the Mater and Beaumont Hospital. As myself, we've got two deep brain stimulation nurses. We have a physiotherapist, Lane Reynolds, and Maggie Garvey, our speech language therapist, and Neil Austin, who's our neuropsychologist, and Sandra Flood, who keeps everything running smoothly. And so this is an important team of people who are all critical in their own way. Before deep brain stimulation, all patients have formal neuropsychology, which is 2 or 3 hours of formal cognitive testing, just to see how robust a person's brain is when considering a general anesthetic. We always like to assess swallow and speech, because speech and swallow can be affected by the placement of an electrode into these areas of the brain. And balance as well, of course, because again, some patients, particularly in Parkinson's disease more than dystonia, balance can be affected or perhaps is on the way to being affected before surgery. So we like to recognize these features before recommending someone pursues deep brain stimulation. So that's Catherine Moran, who joined the service in the end of 2021 and has performed, I think, 25 surgeries now in total in Beaumont Hospital. So this is kind of the structure, if you like, of our deep brain stimulation service. So it's a little bit of an improvement on the ad hoc structure we had before. So again, I suppose we like to have the patient at the center of things, and we accept referrals generally from neurologists around the country, sometimes from geriatricians, and rarely from general practitioners, but predominantly from neurologists. About 98% of referrals come via that route. And we see patients in the clinic in the Mater Hospital, and then we decide if deep brain stimulation is a good idea or not. Sometimes it's clear, sometimes it's not. And if we feel there's a potential for deep brain stimulation, then all these members of the team do very much in-depth assessments. We learn as much as we can about every patient, because we have to answer that important question, is surgery the right thing to do for this person, or could we leave this person in a worse condition than they started out at? And so that we have gathered as much data as we can before we move ahead. This graph just shows what has been happening over the last 20 years. And you can see before the service developed towards in the middle of 2020, we were sending between 9 and 12 patients per year to the UK for deep brain stimulation for all indications. And that was really, it was helpful certainly for those patients who accessed therapy, but I suppose in a sense it was viewed as something that was away in a foreign country, and that was a big issue for patient access. And then it kind of was self-fulfilling, because patients didn't meet many other patients who had DBS, and certainly having a service on the island has made a huge difference in terms of patient awareness and physician awareness, and our referrals are growing very strongly. You can see the exponential rise in surgeries, and we think towards the end of this year we'll be up towards between 60 and 70 surgeries if we carry on the rate we're going. Some of that is due to, if you like, pent-up demand, because obviously there'll be many patients waiting for DBS, and things will hopefully settle down. You'd expect for a country of this size to be performing about 50 surgeries a year for all indications. Dystonia generally worldwide would account for maybe between 10 and 15% of surgeries performed. So, as it says, there are 300 referrals over the last 3 years, representing all 26 counties. 8% of all referrals have been for patients with dystonia or dystonic tremor, or both. And of all the completed surgeries, 10 patients had dystonia. Now, we did say Ms. Moran has done 24 surgeries in Beaumont Hospital, and you might say, well, how come we're doing, between 30 and 60 surgeries? Well, we do have access for some patients to a neurosurgeon in London, and this was a treatment, a National Treatment Purchase Fund project where, because our waiting list was so significant, we would do the preoperative work up in Dublin, and then the patient would travel to London for a single visit, and then come back to us for all post-operative care. So that, we hope, will be a short-term measure while we crank up activity in Beaumont Hospital. But it's worked very well for us. So, as I said, most patients have Parkinson's disease, 68%, 12% for essential tremor, and 11% for syndromes where dystonia is one or the main feature. 31% of referrals from Dublin, Cork second, and Kildare. So it really is we like to think, a national service, certainly not with a waiting towards Dublin. Typical waiting time to be seen after referral is 3 to 6 months, and then about 2 to 3 month waiting time to see the full team. And as I say, in Ireland at the moment, there's 2 surgeries happening per month. We hope to increase that to 3 or 4 over time. So who's a good candidate for DBS? Well, certainly, as you may have heard already, children with generalized dystonia, children with primary generalized dystonia, what would have been called primary generalized dystonia in the past, and particularly certain genotypes, like patients with DIT1 or DYT1 mutations, which we have very few patients with this syndrome in Ireland, certainly more common in North America, associated with the Ashkenazi Jewish population. Adults with medically refractory isolated or focal dystonia where botulinum toxin or other drug therapy has failed to provide adequate symptom relief. And of course, as many of you will know, cervical dystonia is the most common form of adult onset isolated or focal dystonia. Dystonic tremor can respond well to deep brain stimulation as well. Dystonia associated with the use of certain psychiatric medications as a complication can respond well to DBS. And the very rare situation where patients, typically younger patients with generalized dystonia, have sudden acute worsening, a so-called dystonic storm or status dystonicus. Sometimes that's a very, very rare indication for DBS. DBS can be the wrong approach, and it's important to be honest to say this. It's certainly not a panacea or a solution for all people with dystonia. I think it's fair to say, when considering neurosurgery, if your symptoms are relatively mild and managed reasonably well most of the time with non-surgical treatments, in many situations it's best to avoid a brain operation. And even when I'm in the room with Ms. Moran beside me, I'll always say any day you can avoid neurosurgery is a good day. But for some patients, it's the right thing to do regardless. Certainly patients who have ligamentous or tightening or contractures or skeletal issues that are contributing to symptoms, these are things that may not respond or will not respond to deep brain stimulation. And while there are other non-dystonic features, such as spasticity or neuropathy or weakness, these are features that will not respond to deep brain stimulation. So the more pure the dystonia and the more phasic, as a word we use, more free-flowing and free-moving dystonia, the better in terms of response. Obviously, patients who are high risk for a general anesthetic, it's best to avoid surgery. And it's not purely an age thing, but cardiovascular risks, etc., have to come into account. And certain genetic forms of dystonia we know do poorly, and this is the value of the accumulating literature worldwide. So rapid onset dystonia, Parkinsonism, is one particular form of genetic dystonia which doesn't unfortunately tend to do well, unlike many other forms of dystonia. These are hopefully not too graphic, these photographs, but again, just to give the full representation of deep brain stimulation, and there are some risks associated with it. So the hardware can come through the skin. Hemorrhage is a small risk, about 1 in 300, 1 in 400 risk of hemorrhage around the leads. Again, it's a small risk, but as I say to patients, a non-zero risk. It's small, and we've been very lucky to date that I think we have only one patient in the last 15, 20 years who's had this complication, and most patients recover well, as did that patient. And infections, about 5 to 10% risk of hardware infection in the first 3 months after surgery. So these are all important things to consider when making a decision around surgery. Cervical dystonia, I just thought I'd give it an additional mention, given that it's the most common form of dystonia, which many people here, of course, may be living with. And as I said, the majority of patients with cervical dystonia will get reasonably good and satisfactory responses from botulinum toxin, which is minimally invasive and relatively low risk, which is important to say. For some patients, undoubtedly, the response to botulinum toxin is inadequate. And increasingly, as neurologists, we recognize that for many patients, they're just getting by and maybe not getting the quality of life they need to get. Some patients have early wearing off of benefit and find a month before their injection that they just have intolerable pain or discomfort. Some patients with very complex types of cervical dystonia, where there are many muscles involved, or sometimes deeper muscles, are certainly challenging for us as neurologists to treat. Sometimes these are patients where we consider, after a period of trialed botulinum toxin, we'd consider them for surgery. Where there's a phenomenon of secondary non-responsiveness to botulinum toxin, which I won't go into much detail, but some patients after many years of good benefit will find that the toxin does not work as well as it did. In truth, that's infrequent, maybe 5% of patients over a 10-year period of treatment, but it can happen, and these are patients who we do consider for deep brain stimulation. And where sometimes there are other features that are not amenable to botulinum toxin, along with cervical dystonia. So cervical dystonia with a bad upper limb tremor, for example. The tremor in the limb doesn't tend to respond to botulinum toxin, so you can make an argument for using DBS to manage both the cervical dystonia and the tremor. That's just some data we gathered during my days in Toronto, and we looked back at patients and their long-term benefit from DBS. And this generally fits in with the literature in DBS. This is the Twister severity score. It's a 35-point scale. The higher the number, the worse the excessive movement from dystonia. And we tend to see a 50 to 60% improvement. And these are patients with a mean follow-up of 94 months. And since then, of course, more and more data has emerged, and please don't get too lost in these graphs, but blue bars are baseline, the orange bars are up to 3 years, and the grey bars are up to 16 years. And then you can see sustained benefits. So this middle group here is segmental or cervical dystonia, just 10 patients in this group. But we can see in excess of 50% improvement, which was sustained over time. And this was seen on all other measures as well, both for generalized and segmental dystonia. So it's quite consistent in the literature that DBS, over a long period of time, in excess of 16 years in the data, provides moderate to marked improvement in dystonic symptoms for some patients. This is the challenge, and again, this is the last graph I'll put up, but it's a useful meta-analysis that was published. Again, if we look on let's see the top left, you see 0 to 100, meaning the improvement in Twister score. So the higher the dot, the higher the improvement, the top being 100%. And along the x-axis then we have time. So you can see certainly as time goes on, if we just look at this top right here, this is movement, so the amount of excess movement in cervical dystonia. Over time, more dots move upwards. That's one feature of dystonia and DBS, that unlike tremor, which you can see switching off sometimes in the clinic in front of you, the benefit from dystonia tends to evolve gradually over months and sometimes even years. And so you can see more dots move upwards as time goes on, both in terms of the movement severity, in terms of the pain response, and disability. So over time, DBS works better. And some patients, for example, have 100% improvement in pain and close to 100% improvement in involuntary movements. The challenge in using dystonia using DBS to treat dystonia are the people who fall into this lower group. The response is generally considered in the literature about 25% improvement. And some people would find that unimpressive, and I'm sure as a patient that might sound unimpressive, but for some people it's significant, particularly if it's a very severe form of dystonia. But for reasons that are sometimes unclear, there is always a cohort of patients, and maybe perhaps 1 in 5 patients, who get an inadequate response to surgery, which is difficult, of course, having gone through neurosurgery. There are some factors that we think can predict that, and certainly I've indicated some of the syndromes where DBS tends to respond well. Mobile dystonia is better. Patients with a very fixed dystonia, where, for example, one's ear is trapped in a painful, tight way without much mobility to it. Patients who are more mobile do better. Certainly if there's an absence of bad degenerative changes in the neck, for example, because if pain is due to bony changes in the neck, it's not going to respond to DBS, unfortunately, compared to a patient whose pain is largely due to those involuntary muscle contractions. And so there's some suggestion, but nothing very firm in literature, that younger patients do better and more severely affected patients do better. So I thought it'd be just useful to show a video. Naturally, patients being treated in Ireland are understandably not enamored about the idea of having their video shown, but this gentleman was one of our recent patients, and he was very happy to have his video shown. He has a slightly unusual dystonia, which involves both hands and his muscles around his mouth, and it seems to be a familial or genetic dystonia, which we haven't been able to pin down the cause of in terms of a specific gene. So it's a familial, late onset dystonia, predominantly involving upper limbs. And this is just his video when he came down to us. And so show me where that hand wants to be. Where does your hand want to be?
There.
Up in there.
You say something like that.
And spread your fingers. So his fingers continuously want to flex and pull back towards his chest. So he's kind of wrestling with them there. And turn your hands sideways. Keep your eyes and keep them straight as you can. Keep your eyes closed. So very disabled, he couldn't tie his shoelaces, was going to his neighbour's house to have his shoes tied, and then just started wearing slip-on shoes because of it, difficulty using cutlery, huge challenge eating and needing assistance. So very difficult dystonia. He had a trial of botulinum toxin to his arms, but was ineffective, and drug therapy just caused unpleasant side effects. So he was one of our first patients treated with dystonia in Beaumont Hospital. And like all neurologists like me, want is for our fantastic neurosurgeon, Miss Moore, to send back lovely images of the electrodes being exactly where we want them to be. Sorry, just go back there one moment, sorry. So the electrodes we see here, the X-shaped structure here is the optic tract. So that just sits below the globus pallidus. So I showed you the MRI with the globus pallidus a moment ago, and just beneath it is the optic tract. So in the days where the surgeon would go in and burn a little hole, they could burn a little hole in the optic tract and leave an area of blindness, which was a huge concern. But that's no longer an issue with deep brain stimulation. And you can see Ms. Moran has placed the electrodes perfectly in the right spot, which is what how we want to start off with. So at least we know that the electrode is where it should be, and then I suppose it's over to the neurologist to try and push electricity into that region to try and inhibit these unwanted movements. This is what we see in the clinic. This is our programming platform, if you like. And this little sphere, again, which in the old days would have been a hole, which you can't take back once you've made a hole, but now we make a little sphere of electricity, which does the same thing as a hole. And we can see the structures around, of course, which we want to miss. That red slug-type object you see is the important movement fibers heading down towards the speech and the arms and legs. So we can shape our stimulation to avoid important structures, which is a wonderful advance and makes our job all the easier. We have electrodes which are becoming increasingly more complex. We have segmented electrodes where we can push stimulation out one side or the other. And we have multiple contacts on some electrodes, which gives us more bites of the cherry, if you like. If we're not in the right area, we have a greater chance of having a contact just where we want it. So advances are happening all the time. Even over the past 5 years, there's been a phenomenal expansion in our ability to treat patients with dystonia. We can shape the field we are stimulating with. So this is a patient who had dystonic tremor. So we were interested in the thalamus and what we call the zona incerta. So we can shape the stimulation with these long leads to stimulate both areas in certain patients. And this is the gentleman who we turned on his battery a week ago, and he went off to IKEA and had a plate of peas for the first time in 4 or 5 years. So a nice response, a nice early response. And again, a huge credit to Ms. Moran for getting him into Beaumont Hospital. And an example of how deep brain stimulation can restore function, again, without being destructive to brain tissue. So to summarize, DBS is an important option for dystonia that can restore quality of life where other treatments fail. It's not for everyone by any means. People in Ireland now at least have access to deep brain stimulation, which previously needed application for government funding to travel abroad. Benefit can take time to evolve, and some patients, the degree of benefit is a little disappointing, there's no doubt about it. And that's why patient selection is so important. And the decision to move to surgery should be taken as part of a multidisciplinary team, like we have in Dublin. Future developments, just to finish up, well, again, we're always looking for better targets or better options in dystonia and other movement disorders, and there's interest in, and there has been for some time, in the subthalamic nucleus, which seems to be equivalent to the globus pallidus as a target for dystonia. In some patients, maybe dual targeting is the better approach, putting in 2 leads or using 1 lead to hit 2 targets. There's an evolving understanding of sensing batteries. So these are batteries where they actually measure neural activity. I talk about those oscillations of electrical activity happening in these loops in the middle of the brain. So we can actually measure those in the same way that surgeons in the patient awake in the operating theatre can measure brain waves, for want of a better expression. We can now measure brain waves in a patient sitting in front of us in the clinic, and they can go home and feed back this information to us. So we're only really exploring that now in dystonia. And ultrasound, and I'm sure there will be questions about the role of ultrasound, which is a way of creating a little hole, if you like, without opening the skull. And so that's of interest for some people where general anesthetic or surgery is not something that they're interested in or suitable for. It does come with the same limitations of lesion therapy that was in vogue in the 80s. However, it may be an option for some patients, and hopefully in dystonia we'll learn what its role is. So I'll finish there. Thank you very much for your attention. Thank you.
Thank you. That was a fantastic overview, and I hope it was helpful to hear. I don't know if there are any questions in the audience. The microphones might be... I don't need to hit the microphones again. I might ask a quick question while we're waiting for the microphones to go around. Talk a little bit about age as a prognostic factor, and I had a conversation with somebody earlier on in the day. So I said, oh, this would be good for somebody who's young, and there's a certain age at which maybe you wouldn't consider it. And I was going to ask about focused ultrasound actually as well. Would you mind talking a little bit about what sort of ages for dystonia, for example, might you consider surgery? What sort of options for surgical options would you think about at certain ages in broad brush strokes?
Sure. Well, certainly I think some of the association with ages, relates to the fact that generalized dystonia responds so well, which tends to be in younger patients. And there was the first cohort of patients over time in whom DBS was applied with such success. There are some very broad, as you say, lines in the sand around age, and certainly in the NHS, and I think still to this day, 70 is considered a cutoff for surgery, largely due to the operative risk. Just the fact of the matter is that the older you are, a long period under general anesthetic can be a huge challenge, and certainly I've been surprised myself in sometimes meeting patients who've come back who've had surgery in their early 70s, and certainly people can be considerably more frail, if I put it that way, after 6 hours under general anesthetic. The other question that comes up with dystonia, I suppose, in patients who are a little older is if one has lived with dystonia from your 40s into your mid-70s, and having adapted to what is a relatively static condition for some people, is your mid-70s the time to embark on a general anesthetic? That's another reason why age sometimes comes into it. But as you know, we recognise these days that we meet some 80-year-olds who are as biologically fit as some 60-year-olds we meet. So certainly there's no absolutes when it comes to age, but there are some general principles which I think we try to stick to.
Brilliant. Any questions?
Thank you very much for brilliant, talks today. But just to ask you, is it true that in America, general anesthetics are no longer used very much, that they're using the same therapy for pregnancy for women and relaxation therapies? Is that true about America? I'm not quite sure.
You might repeat that again, sorry?
Yeah, I've heard
Is it
that
true that
general
general
anesthetics are not used that much in America anymore, that they're using the same therapy for pregnant women, this, therapy that's used for a woman who's pregnant, and relaxation therapies. I heard that's what they're using now in America, rather than general anesthetic.
Specifically where DBS is concerned, is it?
No, just
in general.
with any
General.
case. Yeah, just wondering. That's what I heard. Anyway, we had a lecture in Rathmines on the history of anesthetics, and that's what came up. So I'm wondering, is it true? I thought it was, I was very surprised at that, but I was wondering how true it is.
Yeah. Well, I suppose, again, where DBS is concerned, if anything, the move is towards more general anaesthetic. So more and more centres are starting off like ours with patients being asleep for surgery. But I guess, as you'll often hear in presentations about dystonia, people with dystonia are a very mixed group of people with many different causes and etiologies, and so it's very hard to generalise, I guess, is probably the best answer to give you. Yeah.
Okay, thank you. Thank you so much.
A related question to general anesthesia, very naive question. Why do we use general anesthesia? I remember functional neurosurgical interventions we traditionally have without general anesthesia, just to control movements and to have tasks for patients. And if you can explain a little bit more, you need myorelaxation or you need just a deep relaxation? What's the reason of general anesthesia?
So as I said early on, the importance of having an awake patient was that general anesthesia would interfere with those electrical patterns that were used to guide the electrode. So the surgeons would have a whole bay of computers behind them, and a neurophysiologist would be listening out for very fine signals that every millimeter the surgeon would advance would say, oh yes, you're approaching the target in that sense. And so general anesthesia would wipe out that activity. And so that activity was used both as a target, so it was important for the individual patient, but it was also teaching us about what was happening deep in the brain. The reason why general anesthesia is used increasingly now is, I suppose, in a sense, a lot was learned from all those surgeries that happened over the years in terms of the academic exercise of learning what's going on within the brain, but also simply for patient comfort, because it's very uncomfortable to have one's head, essentially the skull is screwed into a frame, like you saw in the picture I showed you, and to be awake for 4 hours, it can be very, very uncomfortable, particularly for patients with Parkinson's disease, but also for patients with dystonia where you've got postural abnormalities. So as you know, most or all, for the sake of argument, all movement disorders settle down when patients are asleep. And so for someone with a generalized or even a cervical dystonia, when their patient is anaesthetized, their movements are free, and so they can be put comfortably in a frame. And so just to be awake would be far too unpleasant and distressing and uncomfortable. Yeah.
Any other questions? Let's one more. Stay over here.
Hi, I'm thrilled to hear that it's happening in Ireland now. The class is brilliant. Myself and Christine have had DBS in UK. Can we assume that our battery replacement will happen now in Beaumont, even though we were treated initially in the NHS? We can. Great news. Thank you.
Great. So if there are no other questions, I want to thank Professor Walsh again for a fantastic talk.